Tuesday of each month from 12:15 to 1:15. Today's topic is managing ADHD in pediatric primary care. And we know this is a popular topic by the number of people that registered for today's webinar. Just a few notes before we start. The session will be recorded. So please keep that in mind, and it will be available on the MCPAP website at www.mcpap.org under the For Providers tab. Under the diagnoses, if you look under ADHD, it will be on that page. And both the entire webinar, including the recording, as well as a separate link to the slide deck will be available. Our presenter will stop for questions at the end, so please hold your questions till the end. However, you can type them into the question box at any point in time, but we will be addressing them at the end of the presentation, and there'll be plenty of time for questions and discussion at that point. So again, please use the question box to type in your questions. If you, for whatever reason, can't do that, you can click the raise hand button and I'll be able to unmute you at the time your question will be answered. You're going to receive a very brief survey following the presentation, and we hope that you'll take a moment to complete that. That feedback helps us to improve our future presentations. One note today that we wanted to mention, MCPAP is developing a guideline relative to prescribing FDA-approved medications versus off-label prescribing. This guideline will be available in the next couple of weeks. We'll make sure we send it out to everyone. However, with that said, our consultants are always available to discuss questions about safe and effective pediatric psychopharmacology should you have questions, and feel free to ask questions during your consultation. I am going to turn this over to Dr. Michele Reardon, who is a consulting psychiatrist at our North Shore Medical Center MCPAP team. Dr. Reardon received her medical degree from Pennsylvania State University College of Medicine. She completed her residency in pediatrics and psychiatry and child psychiatry at Brown University. Triple board certified, she previously worked as the training director at the adolescent unit at Kearney Hospital in Dorchester for 3 years. Dr. Reardon is the medical director for the partial hospital program at North Shore Medical Center, as well as the MCPAP team medical director. I'm going to turn it over to you, Dr. Reardon.
Thanks, Marcy. I appreciate it. So we can start off, if you want to go over to the next slide for me. Great. So we're going to start off. I don't have any disclosures to make. I'm purely a clinician, so usually the way we start most of these presentations is that we start off by talking a little bit about a case and presenting a case, talking about the diagnoses or the particular disorder, and then going back and wrapping up a little bit about the case as well too. So the case that I picked to discuss for you guys today is the case of a little boy that was sent into our clinic with ADHD, who had just entered first grade, and we were asked to evaluate him because there was a question about mood and perhaps bipolar disorder. And this is actually a question that is referred to us quite a bit, I think, here in our clinic and here at MCPAP. So I thought it was a pretty relevant case to bring up and to discuss, and I thought it was a pretty relevant topic to help highlight to all of you as to how and when do you determine when do you know kids, well, when to worry about mood disorder in kids, and when can you really determine that kids are more purely moody or getting frustrated because of their ADHD. So this particular case is a little boy, 6 years old. He presented in the care of a foster mother after being removed from his biological mother for neglect and abuse about a year prior to his presentation. He had prior diagnosis of ADHD since about the age of about 4 or 5. according to the foster mom, and had been treated with Adderall and Reardon when he was in his biological family's care, but the family had not been compliant with that treatment. His birth and development was unknown to his foster mom, but according to the foster mom, he was a healthy kid, and the foster mom didn't know of any known concussions or seizures at all. Next slide. Symptoms at the time of presentation include issues with focus, concentration, distractibility, and impulsivity that had partially responded to regular Adderall 5 milligrams a day that he was receiving. However, the foster mom had felt that the Adderall had caused some facial tics and was also causing him some irritability, and felt that JL was a little bit more irritable on the Adderall. There was no history of any aggression, any mood issues or sleep issues, no anxiety or any frank mania, and the foster mom really described this little boy as being a very happy little boy, as a very bright and smart child who was doing well academically in the public school system they were in. Family history was positive for a mom who did have some mental health issues, but it wasn't really clear what mental health issues she had had, and a dad who had a history of domestic violence and abuse towards the family members and had been incarcerated. The CAPS, which is a questionnaire that we use here at the MCPAP program, which helps screen not only for things like ADHD, but also for anxiety, depression, and mood disorders, as well as oppositional behaviors, was filled out, and at that time was notable for severe ADHD as well as some mild to moderate ODD that was filled out by the foster mom. Next slide. So, as I mentioned initially, he's referred because of concerns about his mood issues and to help with his medication management by his PCP. There was definitely concerns about the history of neglect and trauma in this little boy. He was on amphetamine, but there was some concerns about it affecting his mood and contributing to his tics. Office stimulants, when I'd asked the foster mom how this little boy looked off of stimulants, she said that he was aggressive, he was very impulsive, very disruptive. He had a history of pushing peers. He was very easily frustrated. He used to tantrum and cry a lot with limits. Foster mom described this little boy as a happy child, but she also worried that because he didn't seem to have any fears, he would get hurt when he was running around and playing. The foster family denied any mood issues. They denied any history of him hurting himself or any anxiety issues for him. However, he did have some significant sleep issues, and at nighttime would wake up in the middle of the night around 10 or 11 o'clock crying and screaming, but had no memory of this the next day. There was neuropsych testing that was pending at the time he was seen in our clinic that was supposed to be completed through the school and through the Department of Children and Family. And additionally, this little boy had both in-home services as well as a mentor that he was receiving through their local mental health center. Next slide, please. So just to shift a little bit and talk about ADHD and talk a little bit about epidemiology, about diagnosis and treatment. What we do know about ADHD, most people know the statistics that ADHD exists in about 5 to 10% of children. It's noted to be probably the most common disorder among children. It exists across all cultures, across all genders, across all societies, across the world, although it is more common in boys than girls. There's a very strong genetic component to ADHD, as well as there can be a very strong environmental factor that plays into ADHD. So we do know that there are things like lead poisoning that can contribute to ADHD, cannabis, prenatal exposure to drugs such as cocaine, opiates, nicotine, alcohol, all have been linked with ADHD. It's important to remember that ADHD is a developmental disorder, meaning that kids are born with ADHD, they're born with frontal lobes that are wired for ADHD, and it's there, and they continue to kind of develop throughout their childhood and adolescence with this disorder. So it's there from the get-go, and it's there to various degrees, and it's there throughout their childhood. It can exist and present on a spectrum, so it's important to also remember that as well. You can have kids that can present as just predominantly inattentive, or you can have kids who present as incredibly hyperactive, very moody, very aggressive, and you can have kids that present somewhere in the middle. So sometimes we have kids who present more with mood or behavioral issues to us and aren't presenting with academic issues, and sometimes we have kids who are presenting more with the academic problems. And just because kids may be doing well in school does not necessarily mean that they don't have ADHD. Our frontal lobe is a really important part of our brain. It makes up about a third of the brain. It's responsible for more than just attention and concentration. It's not uncommon to see a variety of symptoms it's not uncommon to see a variety of symptoms that can exist with ADHD because our frontal lobe is so big and because it's responsible for doing so many things. And because our frontal lobe also has a portion of it that's responsible for mood, you can see a lot of mood symptoms that exist with kids with ADHD. It is important to try to differentiate those children who are moody, reactive ADHD kids, so they're not mislabeled as kids who have bipolar disorder. And DSM-5 has tried to go a long way to try to help with that and try to clarify, and they've added a diagnosis of what we call disruptive mood dysregulation disorder now to help with those moody, dysregulated ADHD kids so they don't get mislabeled early on. Next slide. So the diagnosis, the criteria in DSM-5 is basically the same as it was in DSM-4 with a couple of small little changes. And those couple of changes include one that you can now diagnose kids a little bit older. It used to be that kids had to have symptoms before the age of 7, and now kids can have symptoms before the age of 12. And for adolescents, you only have to have 5 of 6 symptoms instead of 6 symptoms or more. So the diagnostic criteria are persistent patterns of inattention and impulsivity that are going to interfere with functioning. They have to be persistent. They have to cause. They have to be developmentally appropriate for that child. They have to cause problems with their functioning, and they have to present in at least 2 or more settings. The symptoms cannot occur exclusively during the course of another illness. So for example, if the kid is really depressed or if the kid is struggling with bipolar disorder, they can't just be having those symptoms within their bipolar disorder or depression, although they certainly can have ADHD and then comorbid depression. Next slide. So just to talk a little bit about the anatomy of the frontal lobe, understanding the frontal lobe I think really helps, at least helps me understand kids with ADHD and helps me recognize kids with ADHD and helps me understand and recognize kids across the spectrum. Your frontal lobe includes parts of your premotor cortex, your frontal eye fields, and language, including Broca's area as well as mood. It's pretty big. Like I mentioned before, it's about a third of your brain. Functionally, you can live without your frontal lobe, but you can't function without your frontal lobe. So it really is a pretty underappreciated part of our brain. Your frontal lobe does a lot for us. It not only helps us pay attention, but it also helps us process information. It has parts of memory for us, not those parts of memory that are factual memory. Those parts are in our hippocampus, but what we call our working memory. So the ability to hold on to information and be able to complete tasks are that's part of our frontal lobe. Your ability to get up in the morning and make a cup of coffee is part of your working memory. Sensory discrimination is part of your frontal lobe. Reasoning, organization, motivation is all found in your frontal lobe. Impulsivity, novelty-seeking behaviors, shifting your attention is part of your frontal lobe, and so kids with ADHD oftentimes find themselves in places where they're getting stuck, where they're rigid, and where they're becoming oppositional with people because they're not able to change or shift their attention and not able to transition very easily. because of things. They get very easily frustrated, and because frustration and your frustration tolerance is found there. Fine motor and mood are all found in part of the frontal lobe. Next slide. All this can result in children who can present with not only symptoms of ADHD, but also they can meet for criteria for other things. So, for example, their inability to be able to discriminate or filter out sensory stuff in their environment can actually you can actually have kids with ADHD also have comorbid sensory integration problems. You can have kids who are so moody and easily frustrated that they have overlapping mood disorders. The inability to shift their attention or be able to transition can lead to problems with oppositional problems and oppositionality. Their inability to be able to pay attention and attend to the world can lead to pragmatic problems and social problems for them. Their language in that broca area can lead to language and learning disabilities, and there's a lot of comorbidity with dyslexia and nonverbal learning disabilities in these children. The anterior orbital portions of your frontal lobe have connections with our limbic system, in particular with our nucleus accumbens and our amygdala, which are really important for fear response, risk-taking behaviors, emotional decision-making. So these are children who are very high risk takers. They're kids who are at risk for getting in trouble with substance abuse and other high-risky behaviors because those parts of their brains are not very well developed and are underdeveloped in many of these children as well. Studies have also shown associations between the anterior parts of our frontal lobes and disorders such as schizophrenia, bipolar disorder, and OCD. And so there's links with those disorders as well. Next slide. When you talk about the presentation of ADHD clinically, there's three predominant types. We talk about ADHD hyperactive type, ADHD inattentive type, or kids can be combined. Females tend to have more of the inattentive ADHD. Males tend to be more of the hyperactive or combined type of ADHD. DSM-5 also has allowed us now to have a criteria where we can say whether or not kids are in remission, or can also say the severity of how severe the kids are. So that's new for us from DSM-4. Children may present at any age. They may present early in grade school or even preschool, or they may present in adolescence or even in early adulthood. So it's not uncommon for us to see kids throughout the age groups. Typically, we tend to see kids either as they're entering school or as they're transitioning from middle school to high school level. So those transition school tend to be a very critical time for a lot of kids where they start to struggle. Some of the complaints we tend to see, especially here in the clinic, include academic failure, oppositional behaviors, aggression, mood issues, a lot of anxiety with kids, school phobia, social peer issues. We can see kids who present with a lot of somatic complaints, a lot of kids who are going to nurses or complaining to their parents that they're not feeling well, or they're going to the pediatrician complaining that they're not feeling well, but no one's finding anything on them. So those kids are kids that sometimes when you have those kids, you may want to do a little bit more searching to see if maybe there's some issues with attention or focus there that they're not able to really verbalize for you. Try to be mindful that ADHD is a developmental disorder, and if you are, it really can help differentiate when it's ADHD versus when you may have a depression or other anxiety disorder that's there. And so I always say that mood disorders, depression, are episodic. So when I have someone who's depressed, then they should be able to tell me that there was a time onset to that depression, that that depression started 6 months ago, that depression started a year ago, and that there's been a course to that depression. But I shouldn't hear from the parent or the kid that they have always been a moody, easily frustrated, depressed kind of kid, or that they've always been a reactive kid, or that they've always been a kid who's kind of flown off the handles, or been a kid who's always been explosive or aggressive. Those kind of kids are the kind of kids that I think to myself, that's a wiring issue. That's the kind of kid who is neurodevelopmentally born that way and wired that way, and that's going to make me think more of ADHD. But even in the absence of an underlying mood disorder, parents will describe that their children are easily frustrated, that they're oftentimes moody, that they walk on eggshells around many of these kids, that they feel like that their kids are unpredictable. And as a result, these kids can be really difficult to parent for parents, and they can be really difficult for parents to care for. Unlike the mood disorders, parents would describe these symptoms as being present from early on. They may even describe their child as being colicky, having a history of temper tantrums from the time they're toddlers, being kids who can't self-soothe. They don't take those periods, take those discrete periods of days to week, but is described as moment to moments. And these kids tend to be much more reactive to their environment. So these are kids who are reacting to the people around them, their friends around them, the things that are happening to them around them, as opposed to someone who has depression, who kind of internally is depressed and is internally feeling sad, and isn't reacting so much to the environment, but has more internal symptoms of sadness and depression. There are a variety of rating scales that you can use to help evaluate these kids. Most of, I think, PCPs and pediatricians use those rating scales. Connors, Vanderbilt, very commonly. ADHD rating scales can be used to follow how kids are doing. We use the CAPS, as I mentioned here, which looks at a little bit more than just ADHD, and we'll look at other things as well too, including anxiety and mood disorders. So, but there are several scales you can use and are available to you to use, and we encourage people to use those rating scales to help with the diagnosis and to help with following kids. Next slide. So just to kind of go over a little bit of that, kind of going over a little bit of diagnosis and treatment, and a little bit of the flow of how you would go about this. Really important to, first of all, get a good detailed developmental history of their mood and behavioral symptoms from early childhood, trying to remember that kind of episodic nature of the mood disorder versus the neurodevelopmental history of ADHD. Using your rating scales to help in the diagnosis, remembering to try to rule out comorbidity, and really understanding that comorbidity is probably the rule for most of our children, so that if a kid has ADHD, they're most likely going to meet criteria for something else, whether it be a learning disability, anxiety disorder, depression, or something else. So there may be something else there as well too, and it's completely fair to then refer them to have them seen by someone else to say, I'm concerned that maybe there's some anxiety, I'm concerned that maybe there's some learning disabilities, I'm concerned that maybe there's some depression here. Can you take a look and see if there's something else there as well too? Treatment should be biopsychosocial. It should involve schools. It should involve trying to help get some accommodations at schools to help kids. It should ideally involve social skills to help prevent bullying for kids, parent training to help support parents in their role, and medications. Try not to get frustrated if you're having difficulty finding the right medication, because oftentimes it may take trying 1 or 2 different medications. Sometimes we don't hit on the right medication the first time. Sometimes kids don't tolerate the first medication they try, and it may be that you have to try a couple different medications before you find that perfect fit for kids. And then it's important to reevaluate using scales during visits to assess the need to adjust medications and to see what else you may need to add to that treatment. As I mentioned, comorbidity tends to be high for children with ADHD. It's important to screen for comorbidity because it tends to contribute to a lot of their dysfunction. So about 40% of kids will have another learning disability. About 30 to 40% of kids will have anxiety disorders. Some of those anxiety disorders include obsessive compulsive disorder, social phobia, panic disorder, and generalized anxiety disorder. Sometimes those anxiety disorders are there early on, but oftentimes those anxiety disorders may not present until kids get a little bit older, until kids are entering adolescence. So we tend to see this peak of anxiety disorders for a lot of our kids right around age 13, 14, 15 as they're entering puberty. So it's not uncommon for us to see kids with ADHD that you may be treating and maybe they're doing well, and all of a sudden parents will bring them in around 13, 14 because they suddenly have developed this OCD, or they suddenly have developed this panic attack, or they suddenly have developed this social anxiety. So that is not uncommon to see or hear about. 20 to 30% of all kids with ADHD will have an underlying tic disorder. Tic disorders tend to present on average about a year or so after the onset of ADHD. So if ADHD presents at age 5 or 6 for most kids, tic disorders don't present until age 7 or 8. So sometimes the stimulants can unmask the tic disorders. Sometimes the stimulants can worsen the tic disorders, but most kids who have tic disorders will not have tic disorders because of the stimulants. The stimulants can worsen the tic disorders, but they will have them because they kind of are pre-genetically determined to have those tic disorders. Most kids tend to outgrow tic disorders. Only about 0.5% of all kids will have Tourette's or a chronic tic disorders into adulthood. So there are only a very small percentage of kids who will go on to continue to struggle with tic disorders, but the majority of kids will have transient tic disorders, and those will tend to go away as they enter into adolescence. So as they get to 13, 14, 15, many of those kids will stop ticking for you and stop having tic disorders. And most of those tic disorders are pretty easy to control, and most of those tic disorders that kids have tend to be mild. So sometimes you don't even need to do anything about them. And if you do, then they can be easily treated with some of the medications that we use along with the stimulants, such as the alpha-adrenergic medications, clonidine and Tenex. And those can be really helpful to help with some of the tic disorders. Up to half of all kids with ADHD at risk of an underlying mood disorder as they enter adolescence, so depression or bipolar disorder. So that's a risk factor, especially if they have untreated ADHD. Oppositional defiant disorder and conduct disorder can occur in about up to half of untreated children with ADHD. And we also know that, again, if kids are not treated, there are increased rates of substance abuse, school truancy, retention rates, school failures, and dropouts for these children. These kids run risk of having earlier marriages, pregnancies, being bullied, high rates of divorce, domestic violence, accidents, head injuries, motor vehicle accidents, and job loss. There's also high risks of suicide and suicide attempts. And half of all kids with ADHD will struggle with some sort of sleep disorder. So we probably find about half of our kids will kind of say, oh yeah, I have no problem going to bed at night and falling asleep. But the other half parents will say, my God, they drive me crazy. I can't get my kid to fall asleep at night. They're up all night, or they're getting up and down at nighttime, and they're terrible sleepers. And this is a chronic issue for many of these kids. Treatment of ADHD. Treatment should be biopsychosocial, as I mentioned earlier. It's important to really help educate families regarding ADHD. We oftentimes have many families come to us and they say, well, you know, I've heard that it's important, that you should wait to treat your kid, that you shouldn't treat your kid early with medication, and it's better off if you wait and have your kid treated with medication a little bit later. And really the data and research has shown that that's not true, that it's better if we treat the kids a little bit earlier. The earlier the treatment, the better, and that if we actually start treatment with stimulants early on, it helps with frontal lobe growth and development. And so really giving families some education about that the earlier we treat these kids, the better it is, both for their brain growth and development, and also to help prevent some of the comorbidity that can occur is really important for parents. You want to try to support parents as much as possible. These kids can be really tough sometimes to parent. You want to validate parents around some of that. There are lots of support groups out there for parents nowadays. You want to refer parents to some of those support groups if available. You want to try to get them some in-home support as well too, if needed, to try to help them within the home. As I mentioned as well too, get involved with some social skills groups can be really helpful, especially as they're getting close to the middle school age. So, you know, when they're in grade school, teaching them some of those important skills that don't come naturally to them can be very beneficial and can help prevent them from getting bullied, but also from bullying other kids, because many of these kids will try to fit in, but they don't really know how to do it, and so they end up being accused of bullying other kids when they're trying to fit in with other kids and they're doing it the wrong way. Getting special education plans, whether it be a 504 plan or an IEP, will allow for accommodations for many of these kids, allow them to have extended time, helps with communication between parents and teachers, allows them to have what they need at school with support, and then consideration in some of these kids for additional testing or referrals as you feel maybe needed. If you're seeing some other stuff or if you have concerns about potentially some other learning disabilities, maybe warranted in some cases as well too. So that depends. It may not be available for all kids. It may not be available for all parents or families, depending on insurance or depending on kids. But there are times when you may be treating kids with ADHD and feeling like they're still struggling or noticing that they're still struggling. And then those kids that are still struggling academically, then it is helpful to think about, do they need to be referred for some further testing because we may have missed some underlying other learning disabilities such as dyslexia or nonverbal learning disability that's interfering with their learning. The mainstay pharmacological treatment for kids is stimulants. They are the best treatment. They work the best for kids. So I'm not going to speak directly about particular stimulants, but and as a whole, the stimulants work equally well. But what I will say about the stimulants is that different kids respond differently to different stimulants. So sometimes it's just a matter of finding the right stimulant for the right kid. And I say that to many parents. Sometimes you just need to be a little patient with some of the stimulants. We have lots of stimulants out there nowadays. We do tend to prefer to have kids on longer acting stimulants so that we try to get them as much through the day as we possibly can, so kids aren't rebounding in the middle of the day or when they're coming home from school for parents. But outside of that, there isn't one particular stimulant that's necessarily better than another stimulant for a kid. Next slide. I do oftentimes recommend to many of my PCPs they do consider using a methylphenidate preparation of the stimulants for some of my younger kids, and I do that in part because it's important to remember that the amphetamines such as Adderall and Vyvanse and Dexedrine are about twice as potent as the methylphenidates when you're converting them. So sometimes amphetamines can be just a little bit too strong for some of the younger kids. Sometimes they can hit them a little too much and cause some issues with mood or a little bit too much appetite suppression or issues with sleep. And so sometimes I'll say as a first line, why don't you try a little bit of Metadate, or why don't you try a little bit of Focal and XR, and a little bit gentler to the kid system. So I tend to kind of start there as my first line with some of the littler kids as a preference. But as I said, you may need to try more than one to find that right fit. As I mentioned before, if a child doesn't tolerate one stimulant or becomes irritable with one stimulant, it does not preclude the use of other stimulants. And I have had plenty of kids who they get irritable with Vyvanse, but they do great with Concerta or Metadate, or vice versa. So just kind of try, you may have to go through a couple to find that right one for them. Be careful to differentiate between what is irritability secondary to the medication, and what is medication rebound. So I have lots of parents who will come in and say, well, I tried Concerta, but it made them irritable. And then when I actually sit down and talk to them, it's not that the Concerta made them irritable, it was that the Concerta was wearing off at 2 or 3 o'clock in the afternoon, and they were getting medication rebound with Concerta. So when I sit down with parents, I try to say to parents, tell me what you notice exactly with that medication. When you give the medication in the morning, do you have any period of time that you're noticing improvement of behavior, focus, concentration, and mood for your child, but then you feel like you maybe lose it? Or do you feel like you're noticing some irritability from the get-go? And so that's really important because there's a big difference. If parents say, I give my child that medication and I feel like, you know, shortly after I give my child that medication, I see some irritability or mood issues, then that's going to tell me that it's a medication causing some irritability or mood issues. But if the parent says, no, I give my child that medication, and then I've got 2 or 3 hours and my child seems really good, and then all of a sudden they become really moody, or I'm seeing some issues or worsening behavior, that tells me that I don't have enough medication there and I'm getting rebound and I need to adjust the dose of the medication. So there's ways of kind of differentiating that with parents. It's important to kind of walk through with parents to try to get at that with parents. Many children with ADHD tend to require augmentation of their stimulants, so most children are not able to get through their day with just stimulants. So choices for augmentation include using the alpha-adrenergics such as clonidine, 10X, and the longer acting forms of those. So we have the catapress patch, we've got Capve, we have Intunev. So we have lots of choices nowadays, and they tend to work really well and tend to be really helpful. And as I mentioned, if you have kids with sleep issues, if you have kids with tics, then they can be very helpful to help with a lot of those comorbidities as well too. Wellbutrin, Strattera are also a couple of other options that we sometimes use for kids with ADHD to help augment them with some of their ADHD symptoms. Remember that kids will metabolize and their brains will be able to access medications at very different rates. So I will have teenagers who are on 36 milligrams of Concerta, and then I'll have a 5-year-old who I have on 108 milligrams of Concerta. So for me, it's not so much about dose per kilogram, and it has more to do about the particular kid and their ability, what dose they need and their ability to tolerate their medication. So my rule is always that I start low and I go slow and I titrate up to what the kid needs. And I really titrate up to as high as I feel like they need and as much as they can tolerate. And as long as they're tolerating the medication, I don't really worry about the number and the dose per se, as long as they're growing and eating and tolerating the medication, okay? So I do have some kids who are on some pretty relatively high doses of some stimulants at times, depending on the kid. You monitor for efficacy and you adjust the doses needed, and using your rating scales to help you get at some of, at that is really important. So go on to the next slide. So just to get back a little bit to JL and the case that we had talked about at the beginning. So after seeing JL in our clinic here, we felt that given his developmental history and attentional issues and behavior issues, he did meet criteria for ADHD. We did not feel like he met criteria for any mood disorders or mood issues. We were concerned about his history of neglect and abuse. And did feel like he was at risk for post-traumatic stress disorder, however. We felt that given his young age and that he was having problems with tics, that the amphetamines were probably not a good choice for him, even though they were helping to improve his focus and impulsivity at that point. We recognized that there was something going on with his sleep, and he had a little bit of sleep disorder, and that probably needed to be addressed for him. And so the recommendations that we made back to the team and to the PCP at that time include changing the Adderall over to a long-acting methylphenidate preparation, such as Concerta or Metadate, to help with mood and focus, and hopefully help with some of the tics that he was having. To add an alpha-adrenergic such as clonidine during the day and a little bit at bedtime. This would help with sleep and potentially, again, help with any persistent tics that he was having. And then we agreed with the recommendations and reinforced the recommendations for some of the neuropsych testing and to continue with the services that he was receiving through his local mental health care center, including the mentoring. So in conclusion, I think it's important to remember that children with ADHD can present doing well academically, and that doesn't preclude them having ADHD. And they may present to you struggling with a lot of mood or behavior issues or even anxiety issues. And certainly over at the partial program, we can see many kids presenting with issues around school anxiety and school phobia who end up meeting criteria for ADHD and have had undiagnosed ADHD. And when we kind of treat or address those learning disabilities in ADHD, we're able to help get them back to school and help with a lot of their school phobia issues. Not all moodiness in children is a symptom of an underlying mood disorder, and so being able to remember the developmental context of the mood issues will help you kind of determine whether or not there's really a depression or perhaps something more serious like a bipolar disorder versus is this some moodiness from my kid who's just a moody ADHD kid. Likewise, as I mentioned, kids with ADHD can sometimes present as being pretty anxious because of their disorganization. Again, especially as they get into some of those higher grades. So as kids get into middle school and high school and the academic demands are increasing on them and they're being asked to do more things by more teachers, sometimes they may present to you as just being really anxious, and they may say, no, my focus is okay, but I just feel like I'm lost. I feel like I don't know. I feel like at times I can't keep up, and that really speaks to that working memory piece for many kids, and that processing for many kids, and they can't always put their finger on that for themselves, and they present to people and they present to clinicians as being really anxious, and that can lead to a lot of issues with school anxiety, school phobia, somatic complaints for a lot of these kids. So it's important not to equate symptoms such as the kids feeling anxious or depressed with diagnoses and saying that just because a kid presents to you as being anxious or saying that I don't feel good, that they're automatically depressed or automatically have an anxiety disorder. Try to be mindful, again, that ADHD is a developmental disorder, and I think that will help you in making that diagnosis a lot easier. And it's important to try to screen for some of those comorbidities that can exist and keep some of those comorbidities that can exist in mind, especially as they enter adolescence, because that's when a lot more of those comorbidities will appear for you and appear for kids and become more of a problem for kids. And then refer them for consultation, or refer them if you have any questions and you feel like you're starting to see some of that stuff. Finding the right medication or stimulant for a given child can be a process and it can take time, so don't get frustrated and try to help hold parents and hold kids through some of that and help them understand that it may take you a little bit of time to get that right medication as well too.
Thank you, Dr. Reardon. I think we now have about 15 minutes for questions and discussion. We have one question that's come in so far. How significant weight loss should be to stop using amphetamines?
So say that again, I'm sorry, I didn't hear the first part of that.
How significant weight loss should be to stop using amphetamines?
So I think that depends on the kid, and I think it depends on the age group. So younger kids, I find the weight and growth issue tends to be a little bit more problematic than adolescents, and that's the younger kids that we tend to have more problems with them gaining weight than our older adolescents. So when I start the medications, I say to kids and parents, this is going to be this is going to be your one issue with this medication. It causes weight suppression, and we need to work around this because like this is going to be an important medication for you, so we have to figure out how we're going to get you to eat with this medication, even though you're not always hungry. So let's figure out some like tricks for you to get you to eat. So I try to get parents to really think about that at the get-go. And I say to them, you're going to have to be creative. You're going to have to do things like have, your breakfast has to become your lunch. Lunch doesn't have to be a big thing, but you're going to have to start having 5 meals a day. You're going to have to come home from school and, sit down and have something to eat. And then you're going to have to have something to eat before you go to bed. And then if they're not gaining weight or they're losing weight despite that, then sometimes I will add some appetite stimulants if they really feel like, this is a great stimulant for me. I really need the stimulant. I don't want to switch. And I feel like I really want to stay on the stimulant right now. I may add an appetite stimulant to help with that appetite. So sometimes we'll add things like Periactin. Sometimes, if they're having a lot of sleep issues and they have that sleep disorder, I may add a little bit of Remeron or mirtazapine, which really can be very helpful for their sleep and can help with a lot of anxiety and comorbid depression for kids, and has about a 10-pound weight gain associated with it for most kids. So that may be a choice for me to add as well, too. But if they continue to not gain weight or lose weight, then the discussion may be that, okay, we may have to look at changing the medication over and what are some of the other options. It tends to be more with the amphetamines than it does with the methylphenidates. But you can also have parents, again, depending on the kid, do some holidays with the kids. So, if the kid isn't a kid who's very hyper, very impulsive, then it may be that you say to the parents, well, on the weekends, give the kid a holiday. On, vacations, give the kid a holiday from the medication, or give them a different dose. So there's oftentimes when I may have kids do different doses of the medications on non-school days than I do on school days. So I have them use a higher dose for school days because they need more to get through school than I do on non-school days. And that can be very helpful for the weight issue. So you give them a much lower dose on non-school days, just enough to get them through the day for even those hyperactive kids. And then on school days, you have to give them more because they need more to get through the school day. And that can be helpful as well, too. So I think it always kind of depends risk versus benefits versus side effects, and you gotta kind of weigh all of that stuff. But, anytime you feel like the kid's just continuing to lose weight and you're trying all these other things and it's not working, at some point you have to have a discussion with the family. Well, despite all these other things we're doing, your kid continues to lose weight. Let's try another one and see. And sometimes if you even switch them over to another amphetamine, the weight loss or the weight issues can be a lot less for them. So even switching them over from Adderall to dexedrine can really help with some of the weight issues.
Thanks, Dr. Reardon. We have a few more questions for you. Until what age do you use Vanderbilt's, and how do you screen or diagnose college students?
So I use, I probably use, until what age do I use did you say the screening tools?
Vanderbilt's, specifically.
So I usually use the Vanderbilt's up through high school until they're graduating from high school. And college students, I diagnose similarly to the way I would diagnose my teenagers. There is an ADHD adult rating scale that you can pull up and you can use that is a self-report rating scale that can help in your diagnoses, that you can give to your older patients, so 18 and over, that can help in your diagnoses. So we'll pull that up and use that, and have my a little bit older kids fill that out as well too. Sometimes those kids have already come to me and they've been referred for some testing because they're struggling pretty significantly in college. They went to college and they start to struggle, so their PCPs may have already referred them for some testing as well too.
Great, thank you. The next question is, when is it appropriate to use fluoxetine with stimulants? Would it be appropriate to control anxiety first and then start stimulants?
So fluoxetine is absolutely fine, and the SSRI is absolutely fine to use with stimulants. I think the question about when would you start Prozac or an SSRI first would depend on what you feel like is predominating. If you have, sometimes I have kids come to me and they have significant anxiety symptoms. So they're having bad panic attacks, bad social phobia, bad OCD. And I really need to get them on an SSRI because that is interfering so much with their lives. They can't function, and I need to get an SSRI on board for them. So in that case, I might start an SSRI first and then say, okay, come back and see me in 3 or 4 weeks, and then we're going to go ahead and start a stimulant. And sometimes if I try to start a stimulant with those kids, they may not be able to tolerate the stimulant very well because they're just a little too anxious. So it depends sometimes on the kid and on how much anxiety is there. But there are times when you may decide, I'm going to start a kid on a little bit of Prozac, and it's also safe enough to add a little bit of a stimulant with them for school and say, okay, here, start some Prozac, and after about a week or so of on the Prozac and you get used to the Prozac, I'm going to give you a little bit of Metadate to try for school, and try a little bit of Metadate and come back and see me, and we'll see how you're doing as well too. Remembering that the Metadate is the stimulants are medications that they kind of kick in and they wear off at the end of the day. So they're there and they're gone for you. So you've got that effect right away for a kid. And the Prozac and the SSRIs aren't going to work right away. There is a lag of an onset for all of those medications.
Thank you. The next question is, when do you use each different evaluation tool? For example, the Connors versus Vanderbilt. Do you use a tool to follow treatment, or do you just ask questions?
So usually at the beginning, I would use the Connors or the Vanderbilt to help with the diagnoses. Typically when kids come in, we use the CAPS here with the diagnoses. And then I'll use the ADHD rating scales periodically to help with tracking progress and how kids are doing. Mostly in between that, I will do questions and history, but probably a couple of times a year give the kids the ADHD rating scales and say, how's your symptoms doing, how are things going, to track their symptoms.
Great, thanks. Do I need the DSM-5 for diagnosing ADHD? I use the Vanderbilt. What is the advantage of the DSM-5?
So you don't need the DSM-5. The Vanderbilt takes its symptom list off the DSM. The DSM-5 is there really so that if you have a question about diagnoses and kind of what are the criteria, it's there and it's available for you. Just be aware that there are a couple of things that have changed from our DSM-4 to our DSM-5. So the age criteria has changed a little bit. You don't need as many criteria in adolescents as you do in younger children. So just kind of being mindful that there's those couple of things that have changed from previous years, and being aware of that, and you're fine.
Thanks. Next question is, any words of wisdom for diagnosing an adolescent presenting for the first time in high school years with inattention and school failure?
So I would work up an adolescent in the same way that I would work up any kid, and I think that especially if they're presenting at that age. That transition age can be a particular time when kids will sometimes present to us. It may be that kids had not come to you beforehand because they were doing okay and they were able to keep up with whatever the academic demands are, and as they get into high school, the academic demands become a little overwhelming for them and they start to fall behind. One thing I do remind people to be mindful of as kids get into high school and in middle school and high school is being really good about screening for cannabis abuse and substance abuse and the role that that plays on frontal lobe and attention, and making sure you're screening kids for that and having conversations with kids about that. So, as long as you know that kids aren't, haven't gotten into a lot of cannabis and aren't using a lot of marijuana, and their attention isn't because, all of a sudden I'm using, smoking 2 or 3 blunts a day, I think it's pretty safe that if they're endorsing, if you've got a Vanderbilt and they're endorsing significant symptoms of ADHD and you're not seeing other things there, that they probably, you can probably safely say that there's probably some ADHD there as well.
One last question. Where can we find the caps?
So you can, I think you can actually find it online, because I actually had a PCT ask me that, and I think when they Googled it, they could find it. So, and correct me if I'm wrong, Marcy, it stands for Child and Adolescent Psychiatric Screening Tool. So that if you Google that, it actually will come up, because I had one of the PCP's office ask me that, and they Googled it, and it did pop up for them. So if you Google it, you should be able to pull it up.
There's also a variety of screening tools on our website at mcpap.org under for providers and the diagnoses pages. I'm not sure if that specific one is there. I can't quite remember, but a lot of screening tools are there if you want to take a look at that. So we're running out of time. I want to thank Dr. Reardon for her presentation and discussion. We did get a couple of comments that the audio wasn't great. We're going to reach out to those people that sent us those comments to inquire for future reference. So I apologize for any inconvenience. I want to thank everyone for attending and remind everyone that the webinar will be available on our website in a recorded presentation along with the slides, and that also that the slide deck separately will be available through a link on the website, again on the page with the information about ADHD. Our next clinical conversation will be Tuesday, May 24th, and that will be on autism spectrum disorders. We hope you'll join us for that, and we hope that you'll fill out the brief survey that will come after this webinar. Thanks very much, everyone.
Thanks, Marcy.